I would like to thank the Philippine Pediatric Society Northern Luzon chapter for giving me this opportunity to talk tonight and give you some insights on the common pulmonary problems in patients with neurologic disabilities. So here are my objectives. So caring for a child with cerebral palsy can be very challenging, and especially for their caregivers. And healthcare costs due to recurrent respiratory infections may be really overwhelming. So it is known that respiratory infections are the most common reason for children with neurologic disabilities to require hospital admission. So in fact, patients with cerebral palsy has increased risk of developing more severe pneumonia, and a significant percentage of patients in a studied population developed lung injury from chronic aspiration, which further complicates the condition. So the underlying causes of respiratory illnesses in children with neurologic disabilities are multiple. And in most of these children, these risk factors are simultaneously present. So let me just walk you through this very busy diagram. So here are the risk factors, which we will be discussing briefly. So here we see that the swallowing dysfunction and gastroesophageal reflux, or for that matter, GERD, are potential contributors to lung disease development. And I will be focusing my discussion on these two, as these are the main drivers in aspiration, which potentially causes recurrent respiratory infections and eventually parenchymal injury. So along with these are decreased sensitivity to cough receptors, where cough then becomes very ineffective. So we can also see that the expiratory muscle dysfunction and kyphoscoliosis causes decreased cough efficacy, leading to retention of secretions and thereby causing recurrent respiratory infections, which eventually leads to respiratory insufficiency. So malnutrition also causes respiratory muscle wasting, where respiration becomes inefficient and also causing respiratory failure. So children with cerebral palsy are also at increased risk of obstructive sleep apnea. So in children with more severe cerebral palsy, there is usually abnormal muscle tone of the upper airway and even severe laryngomalacia, which is due to reduced tone in the supraglottic structures, and also pseudobulbar palsy. So this may also cause hypoxemia, which can cause respiratory failure. And so you see, these children are really very vulnerable. So we start our discussion with aspiration, since this is the major proximate cause of lung injury in cerebral palsy. So as we all know, aspiration is the penetration of material below the subglottic area and into the lower airway. So it occurs intermittently, resulting from failure of airway protection that occurs in the setting of repeated opportunities for aspiration to occur. So failure in coordination of swallowing and respiration may be due to anatomic abnormalities within the aerodigestive tract, or there may be disruption of the sensory motor networks of swallowing. And finally, if there are functional disorders of the esophagus or muscles of deglutition. So there are actually two main aspiration syndromes. So an acute aspiration event, which can rapidly progress to aspiration pneumonitis, and in worst cases may lead to respiratory failure. So the other is a chronic repeated aspiration of very small volumes, like the ones we see in patients with neurologic disabilities, and thus will be discussed further in this lecture. So chronic aspiration represents the repeated passage of food materials, gastric refluxate, or saliva into the subglottic airways in sufficient quantities to cause chronic or recurrent respiratory symptoms. And these are the signs and symptoms of chronic aspiration. So we actually see patients with chronic cough. Sometimes there's wheezing, there's choking or gagging with feeds, there's failure to thrive, there's apnea in some cases, there's intermittent fever spikes, recurrent chest infections, and they report wet breathing. So looking back at our diagram earlier, we see that aspiration in neurologic patients may be due to swallowing dysfunction and gastroesophageal reflux disease. So thus, the terms we use, which are aspiration from above, pertaining to the aspiration caused by swallowing dysfunction, and aspiration from below, which points to aspiration caused by reflux. So swallowing dysfunction in cerebral palsy comprises a significant portion causing aspiration. So in a study where almost 1,000 children recorded in Ireland registry, there's a prevalence of 43% in children with CP in any degree. So to date, there are actually no local studies which has documented prevalence of such using the swallowing studies. So first, let us discuss aspiration from swallowing dysfunction. But before that, let's have a very quick review of what actually happens when we swallow. So the oral phase, or the buccal phase, which is the voluntary part of swallowing. So here we see that the food is moistened by the saliva and then chewed, and then food bolus is formed and the tongue pushes it to the pharynx, and this process is under neural control. And the next one is pharyngeal phase, which starts with the stimulation of the tactile receptors in the oropharynx by the food bolus. So the swallow reflex is initiated under involuntary muscular control. So the following actions are taken to ensure that the passage of food or drink into the esophagus is adequate. So the tongue blocks the oral cavity to prevent going back to the mouth, and then the soft palate blocks entry into the nasal cavity. So next, the vocal cords close the airway to the lungs, and the larynx is pulled up to the epiglottis, flipping it over, and then there's covering entry to the trachea. So this is the most important step, since entry of food and drink into the lungs may be potentially life-threatening. So the upper esophageal sphincter opens to allow passages to the esophagus. And lastly is the esophageal phase, where food bolus is propelled down to the esophagus by peristalsis. So the larynx moves down back to its original place. So in swallowing dysfunction, there is premature spillage of material into the hypopharynx, and this occurs when oral movements are not coordinated. So in patients with cerebral palsy, the following mechanisms occur. There is poor oral preparation. There is neck extension, which impairs laryngeal elevation. And there is premature spillage of liquids. And also, there is poor pharyngeal clearance with excessive residual. And finally, there is poor esophageal opening. So in children with neurologic disabilities, there is often aspiration of oral secretions, causing recurrent respiratory infections for that matter. So remember that the oral cavity contains a high density of bacteria and yeast that can cause lung infections if aspirated in sufficient amounts. So please take note that aspiration of oral secretions is caused by the swallowing in coordination and absent laryngeal sensation rather than the excessive production of saliva. So once the clinical examination suggests aspiration and questions asked like the ones Dr. Karen discussed earlier, which suggests aspiration, then a swallowing study should be done to confirm it. So here is a table comparing radiographic evaluation of swallowing, which is the video fluoroscopic swallow studies, or also known as the modified barium swallow. So it has the ability to directly evaluate the oral, the pharyngeal, and the esophageal phases of swallowing, which we discussed earlier. So aspiration of and the penetration of food materials caused by premature spillage, delayed initiation of swallow, there's pooling of secretions or aspiration of reflux material can be seen. However, please take note that the video fluoroscopic studies have limitations, since these are only representations, or this is just a snapshot, and it does not entirely rule out aspiration. So generally, it is a standard evaluation of direct aspiration from above. So on the right side of the table is the fiber optic endoscopic evaluation of, of swallowing, so which is usually performed by an otolaryngologist. So unfortunately, it is not widely available in our hospitals here, but it's available at St. Luke's. So we were able to inquire with St. Luke's and they have it. So since it is an endoscopic evaluation, it has an advantage of not being exposed to radiation. So compared to video fluoroscopy, it does not evaluate the esophageal phase. So there is a documented relationship with GER and chronic respiratory symptoms, and episodes of reflux to or above the upper esophageal sphincter should be thought of as actually opportunities to aspirate rather than a proof of aspiration itself. So in evaluation of reflux aspiration, actually none are sufficiently sensitive and specific to prove aspiration. And the most extensively studied biomarker is the calculation of lipid-containing macrophages in bowel fluid. So however, studies have found out that even elevated lipid-laden macrophage index was not really specific for aspiration caused by reflux. And another biomarker of gastric origin studied was pepsin. So they saw pepsin in tracheal aspirates of intubated patients. But then again, studies have shown that they were not sufficiently sensitive nor specific to prove aspiration. So another important factor contributing to the aspiration is the decreased sensitivity of cough receptors. So we all know that a poor cough cannot adequately clear lower airway secretions and protect against aspiration. And this also needs to be addressed. So the act of coughing involves the following three main components. And if one or more of these three components are impaired, then cough will be less effective. So note that it requires an intact bulbar function, which is usually impaired in our cerebral palsy patients. So as a consequence, there is poor protection of the lower airway when aspiration occurs, and there is inadequate clearance of lower airway secretions. So here are just some of the pulmonary complications of aspiration. So we have aspiration pneumonitis, which is a chemical injury to the lung parenchyma without a defined infectious source, while aspiration pneumonia is a bacterial infection of the lung parenchyma due to inhalation of infectious material. So in more severe cases, there's inflammation of the lung parenchyma progressing to necrosis, cavitation, and abscess formation. So tracheobronchitis refers to a non-specific inflammation of the airway, and it may be infectious or non-infectious. And in prolonged duration of chronic aspiration, we encounter patients who has developed bronchiectasis over time, and its hallmark is bronchial dilatation, and clinically by chronic productive or wet cough, as we have seen in the signs and symptoms earlier. So you see pulmonary infections ranging from simple aspiration to necrotizing pneumonia and lung abscess, and eventually bronchiectasis may all arise from aspiration. So once chronic aspiration is suspected, chest x-ray may show hyperaeration. There's segmental or subsegmental infiltrates and peribronchial thickening. So these findings are usually seen in multiple lobes and independent areas. So here we see a radiograph of a 15-year-old with chronic aspiration. So you can see the posterior involvement or the involvement of the dependent areas. So however, again, please take note that findings of the chest radiographs are are very non-specific, and it usually does not differentiate chronic aspiration from a diffuse lung disease. So this study was done to determine the clinical and the radiologic profile of children with cerebral palsy, and they found out that the radiologic findings were variable among different age groups with involvement of both lungs in almost all cases. So here they reported main findings, which included the presence of hyperaeration, perihilar infiltrates, consolidation collapse, which was mainly seen in the upper and the middle lobes. So here we see a chest CT scan showing dependent bronchiectasis. So there's pneumonia with consolidation and central lobular opacities in a child with chronic aspiration. And this one shows you a lung abscess in an infant with chronic aspiration. So you can appreciate a cavity with thick walls and a central fluid suggestive of lung abscess. So once these lung conditions are diagnosed, then antibiotic treatment is warranted. So a beta-lactam or beta-lactamase inhibitor, clindamycin or carbapenem may be started since the most common pathogens are gram-positive cocci and anaerobic bacteria, and in some cases, Pseudomonas. So ideally, antibiotics should be guided by a sputum culture result. So the duration of treatment would all depend on the extent of the lung damage. So for aspiration pneumonia, a course of 1 to 2 weeks is usually adequate, while longer courses are required for necrotizing pneumonia. So in necrotizing pneumonia or in lung abscesses, the duration of antibiotic treatment is much longer. So we have 2 to 3 weeks of IV antibiotics and followed by a 4 to 8 weeks of oral antibiotics. So it's that long. So treatment should be directed towards the causes discussed earlier. And once we document that there is an ongoing aspiration, we manage our patients by thickening the feeds. And again, preparation of soft consistency food. And Dr. Karen really had a very good discussion on that earlier. So we make sure that there is an appropriate position while feeding, and we consider tube feeding when oral feeding is unsuccessful. So for the management of salivary aspiration, it may be medical or surgical, and oral cholinergics decrease salivation and therefore may decrease episodes of aspiration. However, these are not usually given since there are a lot of side effects, and it should be used with caution. So production of saliva can be reduced either by injection of glands with botulinum toxin or ligation of the tox or removal of the salivary glands. But these are not usually done. So it is beyond the scope of this lecture actually to discuss the treatment options for gastroesophageal reflux, but I just want to emphasize a few points here. So first, acid suppression may not prevent the chronic lung injury from aspiration. So in fact, the use of acid suppressing medications increases gastric colonization by bacteria and may even result in aspiration of material with greater bacterial density. So in children who cannot adequately protect their airways from aspiration due to reflux, we call our friendly gastroenterologist to discuss this matter with us, and then we decide which surgical interventions may be used to decrease the number of reflux events. And this includes gastrostomy, jejunostomy, or jejunostomy tubes, or fundoplication, which is the most commonly utilized. However, unfortunately, in neurologically impaired children, there is a greater incidence of both chronic aspiration and GERD. So a greater likelihood of failure of fundoplication can occur since there is an increased incidence of post-fundoplication retching and decreased efficacy in reduction of the respiratory symptoms. So now to address the problem on impaired airway clearance, we have the respiratory physiotherapy, which plays an important part of the management. So airways clearance techniques work by getting air behind the mucus to open up the airway, and then it loosens the secretions from the smaller airways and then mobilizes them to the larger airways, then clears the secretions from the central airways. So in cerebral palsy, the following techniques may be helpful. So we can have postural drainage, but for this matter, it's a modified postural drainage position. So these are gravity-assisted positioning to drain lung areas of secretion. So actually, the position can include head-down position to facilitate drainage. However, we don't use this, and it has been debated upon due to the increase in the severity of gastroesophageal reflux. Thus, we use the modified PD position. So here, the patient may be put on supine position with the head on 30 degrees up. So usually in the hospital, we just put a towel at the back to support it. And then other positions are prone horizontal position, but please take note for the prone horizontal position, it agitates our patients, so we seldom use this. And we can use the left and the right horizontal side lying and upright sitting for apical segments and upper lobes, which they can tolerate. So percussion or chest clapping is carried out using a hard finger or a hand, or a finger, or a face mask. And in generally, it is generally well tolerated. So nasopharyngeal and oral suction can also help clear the secretions. So make sure that you use the appropriate sized catheter. So in patients with cerebral palsy, suctioning of secretions, especially in the morning, should be done since oral secretions are very thick around that time. So sometimes we send patients home on tracheostomy tubes, so it is important to suction the secretions as well, and tracheostomy care should be taught to the caregivers. So high-frequency chest wall oscillation may also be helpful, but unfortunately, this is not widely available. So I have seen one during my training, but it was sent by a relative who was working abroad. So just to give you an idea how this works, so high-frequency chest wall oscillation, it provides compression of the chest wall at a given frequency, and usually it uses an inflatable vest. So it expands and then it produces a transient or oscillatory increase in airflow and in the airways, and then it vibrates secretions from the peripheral airways toward the mouth. So another important part of airway clearance is nebulization with hypertonic saline, but only if warranted. So hypertonic saline disrupts the structure of the mucus, thereby reducing its viscosity and elasticity, and thus facilitates clearance of airway secretions. So it improves cough-mediated clearance of airway secretions because it actually triggers cough, and cough, as we discussed earlier, increases the amount of mucus cleared from the lungs. So hypertonic saline also works by increasing the amount of sodium in the airways, thus hydrates it, so which thins out the mucus, and finally making it easier to cough out. So chest physiotherapy or airways clearance techniques should be individualized and reviewed regularly as the child grows. So there are actually limited evidence of the role of chest physiotherapy in cerebral palsy patients, and most are actually studies from patients with cystic fibrosis. But nonetheless, these are really helpful in clearing the airways, so we still use it. So in summary, I have discussed with you that children with cerebral palsy often present with chronic and recurrent respiratory problems, and the underlying causes are multiple. And we have discussed the risk of aspiration due to swallowing dysfunction and reflux, as well as impaired airway clearance. And the diagnostic approach should be multidisciplinary. So with that, thank you again for listening and have a good evening.